The true definition of the rapid sequence inhibition, or RSI, is the administration of a potent induction agent that is delivered immediately by a rapid-acting neuromuscular blocker, or an NMB, to render unconsciousness and motor paralysis for tracheal intubation and prevention of gastric inflation. All right, we'll talk some more about this, and we'll kind of go into details about what a neuromuscular blocker is and what tracheal intubation is. So, what are some indications for rapid sequence intubation or induction? So, first and foremost, you need to have an absolute, immediate, life-threatening airway compromise. If it's just someone coughing, or it's someone that has a little tickle in their throat, or something minor with little breathing problems, that's not something that probably needs rapid sequence induction or intubation. What we're talking about is things like, well, let's look at next, status epilepticus, or prolonged seizure activity that is associated with hypoxemia. Now, we all know that when someone has prolonged seizures, basically what happens is they're not getting oxygen to the brain at that point in time. So if you continuously have no oxygen going to the brain, you need to get oxygen to that brain. Well, this person is not going to be able to respond very well to, let's say, high flow oxygen via non-rebreather mask, so you might need rapid sequence induction there. Another is a closed head injury associated with muscle rigidity and severe hypoxemia. Once again, the body's not getting enough oxygen to the brain, closed head injury, you have intracranial swelling, you need to take care of that situation. So another one is uncontrolled laryngospasm that is causing severe hypoxemia. Now, that could be something along the lines of a severe asthma attack. It could be anything else along those lines. Okay, you could have COPD patients. You could have emphysema patients. We're also going to talk about previous intubation efforts or they're unsuccessful. So if you try to do this and the patient starts clenching down, you're not able to get your blade in the mouth, or you're not able to do it via other methods, that's previous efforts that are unsuccessful, and you want to fit the criteria for that absolute life-threatening airway compromise, then yes, this is another avenue to travel. And age range, we want to kind of look at 12 years of age or older. We don't want to be doing, intubating kids. We don't want to RSI kids. So we want to try to keep it at about 12 years of age or older. So when we talk about rapid sequence intubation or induction, we talk about the 7 P's of RSI. The 7 P's of RSI are preparation, pre-oxygenation, pre-treatment, paralysis with induction, protection with positioning, placement with proof, and post-intubation management. Now, for preparation, you want to make sure, just like you do when you get to work every single day, you want to make sure that your equipment is in proper working order. That's the same situation that we want to have with this. We want to make sure that our equipment is in proper working order. So, what we want to do is we want to check our laryngoscope blades, make sure that bulb or whatever we have is white, tight, and bright. Make sure that we have the proper ET tube sizes. Make sure we have the proper medications. Make sure we have syringes. We have IVs, catheters ready to go to start IVs on the patient. Make sure we have IV fluid or IV locks. Make sure that we have enough equipment, a bag valve mask, everything that we need so that we don't have to worry about fumbling around trying to deal with that later. Okay? You want to be prepared, so we're trying to do this as quickly as possible. Then you want to do pre-oxygenation. Now with pre-oxygenation, you want to make sure that the body gets enough oxygen so that it can last while you're trying to do this procedure. There will be times where you might go 30 seconds without giving oxygen, so you want to make sure that you get that oxygen to the patient and that their body has enough. Pre-treatment, that's where you start giving the medication, start doing what you need to do, like starting an IV, getting IV fluids going, start giving them whatever, maybe lidocaine for intracranial pressure. You also maybe want to give them Versed or any other drugs that are pre that paralysis stage. Then comes the paralysis with induction. This is where the meat of it comes in. This is where you've taken away all their ability to breathe on their own, and now they're dependent upon you. The next is protection with positioning. How am I going to get this patient's head? Okay, are they wearing a C-collar? Do I need to hang their head off the edge? Do I need to put them in a sniffing position? What do I need to do? Okay, next is placement with proof. That's where you've actually intubated them now, and you prove it by either saying visualization of the vocal cords, plus condensation in the tube, plus end-tidal CO2 monitoring, plus maybe epigastric sounds were negative, and bilateral breath sounds are positive. That's your proof. Then comes the last stage, which is post-intubation management. That's where you make sure that the patient is not fighting the tube, that the tube is still good, that the tube maintains itself by you securing the tube and making sure there's no holes or anything else along the lines. So let's look at the time frame wise. The time frame wise, you want to see, okay, first and foremost, 0. That is where you have paralyzed them with the induction. That means they are in your hands at that point in time, and you are in control of their airway. So 0 minus 10 minutes is where you start preparing. That's where you start getting your IV ready. Like I said, start getting everything prepared. 0 minus 5 is where you start pre-oxygenating them. You want to get enough oxygenation in them. You might want to start them off with a non-rebreather mask, and then switch over to a bag valve mask. Then you want to get into 0 minus 3 minutes, which is the pre-treatment. That starts getting into the area where you start getting that IV ready. You have started an IV, you start getting your medications. Then it comes to paralysis, like I said, at 0. Then once you get 0 plus 20 to 30 seconds afterwards, you are now protection with positioning. You're making sure that airway is right where you need it to be so that you can intubate. During that time, the 20 to 30 seconds plus 0, now you're going to intubate this patient. Okay, 0 plus 45 to 60 seconds. Notice it's 25 to 30 seconds long. Okay, this is 10 seconds right here. Then you got 25 and 30 seconds long. That way, that's what about time frame you want to try to get in to intubate these patients. So now you do the placement with proof, and we talked about that. Then 0 plus 60 to 90 seconds, but it can continue on as long as you're going with this patient, is the post-intubation management. Okay, so preparation of a patient. So first and foremost, you need to determine that there's a need for a rapid sequence intubation. We're not going to go all willy-nilly and just intubate anybody. So you want to make sure that the patient is prepared and ready. Okay. Next, you want to discuss the procedure with the patient and family if that's possible. Okay. So we know that there's times where you might have an altered mental status patient who needs rapid sequence intubation and nobody else is around. Well, you can't discuss it with them at that point in time. But if a family member or friends or even the patient is able to understand you, discuss it with them. It helps relieve some of that stress, some of that tension, and it'll be a whole lot easier for you in the long run. You want to assess the airway using a Lemon scale. Lemon we'll talk about here in just a second, and then I'll explain it all out to you. Next, you want to see about positioning the patient at the easiest possible intubation position. That means getting them on the stretcher, getting them wherever they need to go, whether it's in the sniffing position, hyperextension, of whatever the position is going to be the best. Okay, so Lemon, L-E-M-O-N, simple enough. First is the L. You want to look at the patient. Okay, I want to look and see what kind of airway do I think this patient's going to have. Do I think that they're going to have an easy airway? Does it look like it's going to be difficult? What do I see? E, you want to evaluate using the 3-3-2 method. We'll talk about that in a second. I've got some slides and I'll show you. Then you want to use the Malin potty, which we'll talk about as well. You want to see if there's any obstructions. And then N is neck mobility. Are they rigid? Do they have rheumatoid arthritis, ankylosing spondylitis? Do they have a C-collar on? So that's some things you need to look for. That's the limit. Okay, so first is L, looking. Is this patient going to be difficult to BVM ventilate? If they're going to be difficult to ventilate, chances are they're going to be difficult to intubate probably. Okay, so there's a little mnemonic that you'll see here in a second about BVM ventilation and difficulty. Okay, you also want to look and see, does the patient appear to have a difficult airway anatomy or laryngoscopy drive? You want to see, this falls into more of the deep BVM ventilation because as you see this, whether it's difficult or not, you're going to probably figure out whether they have a difficult airway as well. All right, so difficult BVM is bones, B-O-N-E-S. Boots, or bones, excuse me, is beard, obesity, no teeth, elderly, and snores. So let's start off with beard. As we all know, facial hair causes a lot of problems. It can create a not so good seal around the BVM mask. Obesity. Unfortunately, larger people tend to have a harder time being able to have a good seal. Next is no teeth. Now this also includes people that have dentures or false teeth in their mouth because they can become hazards and obstructions later on. So you might want to remove them. That way you can see if you can get a better seal. Elderly. Unfortunately, the older population does have a tendency to have problems with BVM difficulty. And last is snores. We'll talk about severe facial burns, angioedema, and trauma here in just a second. Okay, so difficult laryngoscopy anatomy. Okay, so severe facial burns. With severe facial burns, you could have angioedema, you could have other kind of burns. You'll have trauma, whether it might be broken maxilla or mandible. You could have broken teeth. Any kind of trauma in that area can alter the structure that will make it easier or make it harder for you to actually have a good seal for a BVM. Next is buck teeth. Not trying to knock anything, but I have actually seen teeth that stick out almost at a 90-degree angle. It makes it difficult to be able to put a bag valve mask on them and even intubate them. Unfortunately, it's something we have to deal with. Okay? Not trying to knock the man here, but Jay Leno would be a very difficult bag valve mask ventilation. He's got a very prominent chin, and unfortunately, it makes it very difficult. Okay, we'll also talk about Down syndrome and facial features being a little different. Okay, so evaluation of the 3-3-2. Okay, so first and foremost, you want to look and see. Okay, you want to take 3 finger breaths. Okay, 1, 2, 3. Okay, you want to take it between the upper and the lower teeth. You want to be able to visualize. So basically, you take your 3 fingers, stick them in between your top and lower teeth. Okay, if you can fit 3 fingers in there, then that's good. That's 3. Okay, the next is the 3 finger breaths between the mandible and the hyoid bone. So you want to look and see, do I have 3 finger width between here and here? Okay, yes I do. So that's good. That's where we want it. 3 finger widths. Okay, if it's less than 3, it suggests that the larynx is anterior, so it's going to be a more difficult airway. If it's greater than 3, it means that the axes are malaligned, so it could be a difficult airway as well. And then you want to look at 2 finger breaths between the thyroid cartilage notch and the mandible or floor of the mouth. So you want to look and put 2 finger widths right there. If you can fit 2 in there, it's a better airway. Okay? As you can see here, you see up in the top left picture, you see 3 finger breaths there, and you see the 2 finger breaths here. Okay? They didn't show the 3 fingers in the mouth. All right, Malampati. Okay? You have 4 classifications of Malampati. 1, 2, 3, and 4. 1 is the tonsillar pillars and the fauces are visible. Okay? That means mouth's wide open. You can basically see their vocal cords. 2 is the upper portion of the pillars and the uvula are visible. Means you can see down, but you're not going to see a whole lot. It's going to be a little bit more difficult to be able to see. 3 is the base of the uvula or the soft palate is visible. This is where you start getting into a more difficult airway. This is becoming a very difficult airway. 4 is only the tongue and the hard palate is visible. This is your most difficult Malampati airway. The higher the number, the less opportunity to be able to intubate. Okay? So with the patient's mouth wide open and their tongue sticking out, that's how you're going to classify them. All right, so looking at this, grade 1, as you can see over on the far left-hand side, you can see the vocal cords there. As you look down their mouth, you can see basically in their mouth, and you can tell, man,